Good evening, everybody. So I'm Dr. Tan. So thank you for the invitation for this evening's masterclass. So from the infectious disease standpoint, I'll be talking about sepsis and septic shock management. So I based this lecture from the 2021 Surviving Sepsis campaign. And in these 2021 guidelines, we have some modifications and changes from the 2016 guidelines. So sepsis, again, for us to recognize, so this is a life-threatening organ dysfunction because of a dysregulated host immune response. And this is a heterogeneous disease with different clinical courses and clinical phenotypes, meaning to say these patients can manifest with different signs and symptoms, like no two patients will be alike. They can have different clinical courses, but of course, the bottom line is we have to recognize and we have to know that this organ dysfunction is because of a dysregulated host immune response. And if we will be comparing sepsis from septic shock, so this would have the same dysregulated immune response, and which is a subset of sepsis, in which particular profound circulatory, cellular, and metabolic abnormalities are noted and associated with a greater risk of mortality than with just sepsis alone. And this would require vasopressors, like your norepinephrines, to maintain a mean arterial pressure of more than or equal to 65 millimeter mercury, and with serum lactate of more than 2 millimoles per liter in the absence of hypovolemia. So very important is before we go to the management, we should be able to recognize the sepsis and the septic shock. Because from the IED standpoint, we will focus on the infectious management in this guideline. For this item, this has been changed from the previous one. So for adults with possible septic shock or high likelihood for sepsis, we recommend administering antimicrobials immediately, ideally within 1 hour. So this is not a new item, but this was just changed from the previous recommendation, because in 2016, it would receive a strong recommendation with a moderate quality of evidence. But in this 2021, they changed it. So you have to recognize if this patient has septic shock or does not have shock. Because for patients with septic shock, this would have a strong and low quality of evidence as compared to those without shock, very low quality of evidence. Later, I'll show you a picture or a slide for you to be able to understand this more clearly. Now, for adults with possible sepsis without shock, because this is a new item, so it's not seen in the previous guideline. So here it says sepsis without shock. We suggest a time-limited course of rapid investigation, and if concern for infection will persist, the administration of antimicrobials within 3 hours from the time when sepsis was first recognized. Because in the previous guideline, it will tell you that if you have sepsis, you have to give your antimicrobials right away, within 1 hour. But here it says you have to investigate. So they would suggest a time-limited course of rapid investigation. So since the patient does not have shock, you still have the window period, or you still have the leeway for you to be able to investigate. So when you are able to investigate, but if you will be planning to give antimicrobials, still the first 3 hours would be very, very crucial. So this would be for your patients without shock. So this is a summary to help you understand more clearly. So sepsis is definite or probable. So you try to stratify if shock is present or absent. But if you are strongly suggesting or believe that this patient has sepsis, okay, you have to administer your antimicrobials within 1 hour of recognition. But if sepsis is not definite, meaning to say it can be, it is possible, you stratify, is shock present? Or you ask yourself, shock is absent. So if the shock is present, yes, you give your antimicrobials within 1 hour. If shock is absent, so sepsis without shock, we go to this column of the algorithm. You do a rapid assessment on infectious versus non-infectious causes of this acute illness, this acute dysregulated host immune response. If you think that this might still be because of an infection, you have the first 3 hours for you to be able to administer these antimicrobials. So again, you have to remember if this patient is talagang really having sepsis or not. If sepsis is possible, you're not so definite about this sepsis, you stratify. Is shock present or there is no shock? So if there is shock, you administer your antimicrobials within 1 hour. If shock is absent, you investigate. But if you plan to give, you still give it within the first 3 hours. Because studies have shown that if you delay it for more than 3 hours, of course, the mortality and the morbidity will increase. So talking about antimicrobials, so we'll be stating later on in the next few slides, what kind of antimicrobials should you give? Should you cover for all of those possible organisms, antifungals, MRSA, etc.? So again, so for adults with a low likelihood of infection without shock, we suggest deferring antimicrobials while continuing to closely monitor. Because in the old guideline, it will just say give antimicrobials within 1 hour. But in this new guideline, always remember, we want to preserve the antimicrobials first, because there's a reason for that. And I will be talking about that briefly later on. So if you still have time to investigate if this is really an infection or not, if the etiology of this patient's problem is an infectious etiology, you investigate. You try to look into the problems of the patient. Maybe there's a non-infectious etiology. But if you want to give antimicrobials, again, sepsis without shock, you have the first 3 hours for your, decision if you'll be giving or not. Next, the question is, so what kind of antimicrobials will you give? We know for a fact that most of the patients, if they have sepsis, they have this bacterial etiology. And we should not forget, one of those bacteria that is very common to have sepsis or infection or massive infection is because of MRSA. Especially here, we have our crit care specialists here in the hospital. So we have mostly patients who are intubated, mostly those patients with IV catheters or with central lines. So we have to think, do we have to cover for possible MRSA? So what does the guideline tell us? So this is a new item in this 2021 campaign. So it says here, for adults with sepsis or septic shock at high risk of MRSA, we recommend using empiric antimicrobials with MRSA coverage. So what would make you think that these patients would have a high risk of MRSA? So remember, some patients with a history or a previous MRSA infection or colonization, or those who have received recent IV antimicrobials, especially those broad-spectrum antibiotics, history of recurrent skin infections or chronic wounds, those non-healing wounds or skin infections from some staph or from their underlying problems. If they have underlying eczema, so they would scratch their skin, they would have this MRSA colonization and infection. Or presence of invasive devices, which I think for crit care specialists, we deal with a lot of these cases. And patients on renal replacement therapy or with recent hospital admission, and for patients with very, very severe illness. Then you have to think that you might have to cover for a possible MRSA infection. So for adults with sepsis or septic shock at low risk of having MRSA, we suggest against using empiric antimicrobials with MRSA coverage. So this is not a shotgun therapy right now that we want to practice. So if the patient has sepsis, we have to stratify. Does this patient really need MRSA coverage? Does this patient have a risk of having MRSA infection? If your answer is no, you shy away from giving your anti-MRSA antimicrobials. If your answer is yes, then you can give your anti-MRSA medications or antibiotics. So one of those antibiotics with anti-MRSA effect, very good, would be your Linezolid, because we have seen cases of vancomycin-resistant pathogens. So these Linezolid, since they have been in the market, and since we have Linezolid here in our practice, of course, so this is a synthetic oxazolidinone. which has a very good gram-positive coverage for your staph infection, very good, your MRSA methicillin-resistant Staph aureus, or for your enterococci. So they would have very good activity, your Enterococcus faecalis, Fishum, because some of these bacteria will have VRE, or what we call the vancomycin-resistant enterococci. So your linezolid would have a very good bioavailability. In fact, your parenteral or intravenous bioavailability is almost equal to your oral bioavailability of 100%. And this linezolid would also have a very good tissue penetration. It can also cross the blood-brain barrier. So this would be a very good antibiotic choice against your MRSA infections. And since this is a protein synthesis inhibitor, so this would inhibit the 30S and the 50S subunit of your mRNA. So is this a time-dependent or concentration-dependent? Later on, we have a slide on some journals to tell us how should we give these kinds of antibiotics. So let's wait for that slide to come. So I have here some journals. So this is the first journal. Since we want to talk more about linezolid, so this journal is basically comparing the effectiveness and safety profile of 6 antibiotics in treating MRSA infections, and this is a network meta-analysis. So in this study, they made use of the 6 antibiotics. Of course, vancomycin is there, and they want to compare these other 5 antibiotics to the vancomycin. So they made use of the linezolid, tigecycline, ticoclanin, daptomycin in this study. So first, they studied on the effective rate. So on the first item here, for the effective rate, the number 1, this would pertain to the bloodstream infections. Number 2 would be pulmonary infections. Number 3 would be skin and soft tissue infections. So effective rate here, it says here that they found out for patients in the study with bloodstream infections, they found out that daptomycin has the best efficacy rate. However, if you look at number 2, when compared with vancomycin for your pulmonary infections, your linezolid here on the number 2 item has the best efficacy. And also on the number 3 item, skin and soft tissue infections, linezolid will also have the best activity or efficacy rate. So it shows us that linezolid, if you'll be comparing it with the other antibiotics with MRSA coverage, like your tigecycline, daptomycin, ceftaroline, so tigecycline is still a very good option, especially if we are trying to deal with those patients with pulmonary infections like your nosocomial infections because of MRSA, or your skin infections because of MRSA, then tigecycline and the other antibiotics would be a good option. But based on this study, your linezolid would have a very good efficacy rate. And linezolid is also available in the hospitals, in our formularies. And us comparing to the microbial killing rate. So that's item letter B. So the number 1 would also be the bloodstream infections. Number 2, pulmonary infections. Number 3, skin and soft tissue. So for the microbial killing rate, we can see here in this study that the linezolid would have a very good microbial killing rate. And when talking about pulmonary infections, your linezolid would also have an edge as compared to the vancomycins and the other antibiotics. For number 3, so this would be skin and soft tissue, your linezolid will also have a very good activity. Next is the treatment duration. So for the bloodstream infection and the pulmonary infection and the skin and soft tissue infections, we have learned earlier that your linezolid would have a very good activity against these kinds of infections for the efficacy and microbial killing. For the treatment duration, if we can see here, your tigecycline, your daptomycin, ticoclanin, they almost have the same, but it just showed here that the treatment duration is shortest here in number 1 for bloodstream infection among those with your tigecycline group. As compared to the vancomycin for pulmonary infection, still the same. And compared to vancomycin, still the tigecycline. But the safety profile, of course, if comparing them with vancomycin, we know that your vancomycin would have a very nephrotoxic effect. So if we will be choosing your linezolid, perhaps we will have a good outcome for our patients. Although we have to note that some of those patients can have linezolid-induced thrombocytopenia. But how safe would these drugs be? So this second study, so this is the efficacy and safety of continuous versus intermittent linezolid infusion. Because we know for a fact that linezolid is a time-dependent antibiotic. So we want the antibiotic to have a very high constant amount, okay, in the blood throughout the 24 hours. So since this is a time-dependent antibiotic, so they want to study, because the usual practice is we give these antibiotics twice a day, 600 milligrams twice a day. So since some of their audience tonight would also be critical care nurses or nurses in the ICU, so if the physicians would order linezolid, usually we order it at 600 milligrams every 12 hours. So it is not a continuous 24-hour infusion. But since this is a time-dependent antibiotics, if you can prolong the antibiotics, if you can have this blood level of these antibiotics for the entire 24 hours, then it would even be better. But for linezolid, would this be useful? Because in clinical practice, we give it twice a day. So I tried to look into some studies, and I found a journal here. And this journal, I think, was studied in India. It was conducted there. So it states here the efficacy and safety of continuous versus intermittent linezolid infusion in critically ill patients with septic shock. So, of course, they chose the patients with septic shock with microbiologic proof that they have MRSA infections. So one arm, so 70 patients would belong to the group A, 70 the group B. So one group would receive the continuous infusion. So when they say continuous infusion, they load the patient with 300 milligrams of linezolid, followed by 900 milligrams on the first 24 hours, and then 1.2 gram thereafter. So meaning to say that 1.2 gram would be dripped for the entire 24 hours. As compared to the other arm, which is an intermittent infusion group, so we just give it traditionally like the 600 milligrams IV now, then 600 milligrams every 12 hours. So they try to compare. So which one would be more efficacious and which one will have a better safety profile? So of course, the first table, they want to study on the demographics of the patient. So almost at a par. So for the continuous infusion groups, demographics, and for those in the intermittent infusion group, they almost have the same profile of your patients. And they found out here that, look at the last slide or the last row, empiric antibiotic duration almost same, around 4.83 days as compared to the intermittent infusion, around 5 days. So almost at a par. So they want to make a study on the efficacy and they want to look into the safety profile. So this would tell us in this table the clinical outcome. So how were they able to study the efficacy? They studied the clinical outcome, the days on treatment, the days to clinical cure, clinically, microbiologically, length of the ICU stay, length of hospital stay, and clinical cure number. So here they found out that those on continuous infusion, they have a better outcome. Like days of treatment, they just required 7 days as compared to those on intermittent infusion, 9 days. So days to clinical cure in 6 days time, those on continuous infusion, they already achieved clinical cure and so on with a shorter length of hospital stay of 14 days as compared to 17 days. So this study have found out that the continuous infusion might benefit the patients more than the intermittent infusion. And they found out also that for those on intermittent infusion, which also in my clinical practice, and I believe in some of the colleagues of mine, we have also noticed that with linezolid infusion, we see a lot of patients having thrombocytopenia. So perhaps this might be something that we can look into, because I use the intermittent infusion. When I ask some of my colleagues, we have not yet really tried using the continuous. So maybe this is something that we can look forward to in the future on what is the best way to give your linezolid. Since we have discussed that this is a very wise option to choose among your septic patients with MRSA, then maybe the next thing that we can look into is how should we give it? Should we give it at a continuous infusion or intermittent? Or maybe later in the question and answer portion, or some of the audience or colleagues of mine or anyone, you can type in maybe your experiences, you can ask questions or tell us about if you have tried the continuous versus intermittent infusion, or maybe from our pharmaceutical colleagues here. So what are you going to tell us, or do you have more studies on that, more randomized controlled trials for your continuous versus intermittent infusion? Those can be some future opportunities. So the next thing is, after talking about MRSA, since we said that for septic patients, this can be polymicrobial, this can be because of a gram-positive, gram-negative, or one important thing is the fungal infection, which we should not forget. Because for adults with sepsis or septic shock, at high risk of fungal infections, we suggest using empiric antifungal therapy. So this is not a one case for everybody. Because if your patient has some risk for fungal infections, then by all means, you give this empiric antifungal therapy. But if your patient with sepsis or septic shock, but has low risk of fungal infection, we suggest against empiric use of antifungal therapy. So you stratify. Does this patient have the risk for fungal infection, or he does not have the risk? Because this would change your management. If the patient has the risk for fungal infection, based on the new guideline, you give. But if this patient has very low risk of having fungal infections, then you can opt not to give your empiric antifungal treatment. So these would just tell you some of the risk factors for Candida, which is one of the most common fungal pathogens among your patients. So colonization at multiple sites. So if you have patients who are neutropenic, immunocompromised patients, HIV patients, transplant patients, patients with prolonged immunosuppression, patients on total parenteral nutrition, down the line. So if you have some of these risk factors, then by all means, you won't be judged on why you'll give your antifungal therapy. Why are we talking about this one? It is not because we want to be very, very conservative in treating our septic patients. We know septic patients, when you do not address them, when you do not diagnose and treat them early, of course, mortality would increase proportionately. But how come you've noticed that in the newest campaign, how come we are more careful in initiating antibiotics? If you do not need antibiotics right away, you shy away from giving it first. You investigate. If you do not need MRSA coverage, you do not give your shotgun treatment for MRSA infections. If you do not need antifungals, you shy away first. Why? Because this picture will tell us about multi-drug resistant organisms. Nowadays, a little of those antibiotics would be invented out in the market. But yet, our pathogens are becoming wiser and wiser. So we have cases of multi-drug resistant organisms. So we want to promote antimicrobial stewardship. So I think I would like to share that, because from an infectious disease standpoint, it is not just the giving of antibiotics that we have to look into. We do not just get referrals for us to initiate antibiotics. We also get referrals to stop antibiotics. We guide people or our colleagues to not give antibiotics because we want to practice antimicrobial stewardship. Because what does this mean? Because without urgent action, we are heading for a post-antibiotic era in which common infections and minor injuries can once again kill or make the disease even worse. So how can we prevent these MDROs from emerging? By practicing wise and judicious use of antibiotics, an AMS, antimicrobial stewardship, which I think would be important for another topic for our lectures, perhaps in the near future. So very important is you have to record, you have to prevent the infection. You want to prevent the sepsis for the MDROs not to set in, prevent sepsis. You have to track those infections, track the use of antibiotics, and you have to improve your antibiotic prescribing or the stewardship for you to be able to lessen these MDRO rates. And again, very important. Here, because I'm tasked to talk about the management from infectious disease standpoint, the question is, how about diagnosis? Because in diagnosing sepsis, of course, we order our blood culture, which is really mandatory for us to de-escalate or to escalate our antimicrobials. But there is one new thing here in our practice, the precision medicine. I know I have discussed this in one of the crit care postgrad before, but this is just a few slides, just an introduction. Perhaps our pharma company or colleagues would have these future master classes that maybe we can expound further on this topic, because this one can help us diagnose. Because in precision medicine, this is very personalized medicine. This is a new or novel, innovative approach to tailoring disease prevention and treatment for our patients with sepsis. What is the goal? Because the target is you want to give the right treatment to the right patients at the right time. Because sometimes you are just barking at the wrong tree. Perhaps you are entertaining a gram-positive infection, but you are treating these patients with something without gram-positive coverage. You are just giving these patients the wrong antimicrobials because you're still waiting for the blood culture to come out. But with precision medicine, we can study the different genetic profile of your patient. We can study the different biomarkers, your procalcitonin or new novel biomarkers, the host pathogen interactions, personalized treatment, and of course, with a personalized treatment, you give this armamentarium of antimicrobials to your patient correctly, then of course you'll have a better outcome. And of course, you have to monitor the adjustments, the dynamic adjustments for your patients. Because in precision medicine, this is more of a holistic approach. Because in sepsis, precision medicine, you'll be dealing with the bioinformatics about your patient, the biomarkers, immunoglobulins, and toxins, cytokines, and down the line. So this is more of a new approach on how to help us diagnose. Because if you are able to recognize, if you're able to diagnose, you'll be able to treat your patients earlier with a better outcome. So I think this is the last slide of my lecture. So just to give you a summary, did we attain the title that we want to address or to share with everybody? So from infectious disease standpoint, I dealt with the infectious part of the sepsis guideline. And the guideline nowadays, we're practicing the 2021 Surviving Sepsis campaign, because the old one was from the 2016. And in this 2021, we do have some changes and some new items added up. So bottom line here is, if you are entertaining sepsis, by all means, yes, you can give your antimicrobials, ideally within 1 hour. However, if you think that this patient have shock, yes, you give your antibiotics. But if this patient does not have shock, and you are not so sure if this is really an infectious etiology or not, you try to investigate. You try to dig into the details and look if this patient really has or doesn't have infection. And hopefully in the first 3 hours, you give your antimicrobials. Another objective was discussed earlier, the Linezolid. Linezolid is a very good gram-positive bacteria, so it can have a very good coverage for your enterococci, for your MRSA. But we have to think wisely. Should we give antimicrobials against MRSA? If the patient would have risk factors, by all means we give. And so we discussed Linezolid. Should we give this as a continuous infusion or intermittent infusion? In the current practice, we still use the intermittent infusion, so twice a day. But now I can see some journals, actually not just one, but a couple. They're trying to look into the continuous infusion. I myself haven't tried that, but maybe next time we can have some studies on this one, because they found out that it has a better efficacy rate and safety profile. So with that, we talk about AMS, so the wise use of antimicrobials from infectious disease standpoint, and maybe this precision medicine can also help us and our colleagues in the future in preventing and in treating septic patients. So thank you very much.